Good morning. Welcome, welcome, welcome.
Yeah, no, that's great.
As I drop all my polls and my... So, we're all here, are we? Thank you. Welcome to our Race to Erase MS Forum. I'm Claudia Curry-Hill, and I've had primary progressive MS for 40 years. 32 years ago, I had the great fortune of meeting Nancy Davis. She had come to Aspen to do a fundraiser for MS, and I had answered the call to volunteer. She wanted someone to help organize an informative panel on MS. So Dr. Howard Weiner was on that original panel. And Howard, if you could show your badge. This is from 32 years ago.
I love that.
He and I were both brunettes back then. So I was so excited to meet Nancy and learn of her vision of a Center Without Walls. And here we are today. I would like to introduce to you our Center Without Walls program panelists. Dr. Christina Azevedo, USC. Dr. David Hafler from Yale. Dr. Adam Kaplan, Minerva Pharmaceuticals. Dr. Ellen Mallory from Johns Hopkins. Dr. Nancy Sykott, Cedars-Sinai. Dr. Rhonda Voskuil, UCLA. Dr. Emmanuel Wabant, UCSF. And she's also our medical director. Dr. Howard Weiner from Harvard. And Dr. Vijay Yadav from OHSU. And now I'm going to turn this over. Oh, by the way, I've forgotten the most important people on the panel. So if anybody was here last night, you saw Chad King. He's a board member. He was fabulous. He was wonderful. He's a board member for the Race to Erase MS and an advocate for MS. Mark Barondis, who's also an advocate and so much more. And, of course, Nancy Davis. So it's our founder, our hero. So, Nancy, I'm going to turn it over to you to welcome everyone.
Okay. Thank you, everybody, for being here today. It was just quite a weekend. I'm so grateful that last night we had our 32nd annual Race to Erase MS, and it was a huge success. We've done 32 of these, and it's basically like throwing 32 weddings. There's so many layers and work to this whole thing, but the good news is we've had 32 happy marriages, so that's a lot to say. They've all worked out really well. Last night was spectacular. Chad sang last night from A Great Big World, and he was amazingly fabulous. And as I look into the audience, I'm looking at Saida Garrett, who sang last night too. Amazing, brilliant. And we're so fortunate that you guys are all here today. This is an exciting year. If you look at MS, no other disease has this happening, but there's now 25 drugs on the market to help stop the progression of MS. That is nothing short of a miracle. It's happened because of all these brilliant doctors. They have all put so much into it. Race to Erase MS has supported the pilot studies for lots of things along the way. And a lot of us, if you look at Dr. Weiner here, he started with us 32 years ago in Aspen. They've been with us ever since, and there's a lot of loyalty. Everybody's really worked together. Everybody thinks outside of the box. We all have the same passion, the same drive, and the goal at the end of the day is we need to stop MS. We need to cure MS. We need to stop all the suffering. There's some amazing drugs on the market, and it's a miracle that they exist. They're sitting there making everybody's life great. But there's some people who are still, suffering in different ways. So it's our aim and it's our goal to help absolutely everybody until we can wipe MS off this planet once and for all. So thank you guys for being here today. This is the intelligent part of what we do. These are the brains. Everybody here is so brilliant. I look up to everybody here, and I mean, I'm in awe of everything you do and everything you say. And I have MS also. I was diagnosed 33 years ago with MS, and at the time, I was told I would never walk again, and life as I knew it was over. And at the time, there was no known cause, no cure, no drugs in the market, and there was actually no hope that there would be anything. And it was devastating. I was a young girl that was 33 with 3 kids, and I didn't know how I was going to live my life. And I'm like, they told me I'd be able to operate the remote control my TV set, and that was about it. And I was lucky that I could go to get a lot of second opinions from some great doctors around the country. I thought if I could go to enough doctors, they would tell me I didn't have MS. That didn't happen. However, along the way, I listened to the research that was going on, and I was fascinated with the fact that a lot of the doctors worked sort of almost against each other, in that they were all doing the same identical studies and thought that they were the only one doing that exact study, but everybody else was doing the same study. And I thought, wow, if we could put just the best and the brightest doctors to work together and to never duplicate research, but to constantly communicate, we would have the building blocks to find a cure a lot quicker. So here we are with this team of 8 brilliant doctors, 8 brilliant centers, and we're getting there faster than anybody with any disease. So I have them to thank. They are the brains. They're the building block of everything happening, and we're not going to stop until we find a cure. So thank you all.
So now we're going to begin our topics for today. And first is Dr. Howard Weiner. And what is in the pipeline to prevent relapses? BPKLL.
So, thank you, Nancy. I'll say a couple nice words about Nancy. We obviously go back many years. A story that we know is that my family has a delicatessen in Denver. Her family lived in Denver, and her father used to order all this food from our deli. And he was the biggest orderer of food from our deli. So we go back all those years. That's how the Race to Erase MS started in Colorado, because the Davis family was there. I'm happy to report my parents had the deli. My sister has a deli now. Her son runs the deli. It's called the Bagel Deli, and it's now in the airport. So when you go to DIA, go to Terminal A and get something. So I'm listed here as a pipeline to prevent relapses. Let me tell you a couple words. MS has 2 stages: a relapsing stage where you have attacks, and then later a progressive stage. We actually are pretty good at shutting off relapses. There's a lot of drugs to do that, and we've basically succeeded. There's additional drugs we might use to shut off relapses. I'll tell you a couple things that we're working on at Harvard. One, we're working on the microbiome. That's all the bacteria you have in your gut. There actually are over 1 trillion bacteria in your gut. And we're working on special probiotics that could be given to help people with MS and help slow down the attacks. And we presented a plan at our scientific symposium yesterday, and we're going to start to do that, and one of our scientists spoke about that. The other area we're working on is a nasal spray to treat MS. We've started it in progressive patients, but it could work in relapsing patients as well. And this has now gone into clinical trials. Other people from Hopkins, from Yale, and other people on the panel are working on that. So this is some of the exciting new things in terms of relapsing, understanding it better, safe new treatments that can be given with current therapies.
Thank you, Dr. Weiner. And next is new drugs to slow down disability progression. Dr. Ellen Mowry.
Good morning, everybody. It's nice to see so many folks up early. And yes, I think the most exciting thing in the space of medications to slow down progression is that this is the focus of MS research right now. People are really spending a lot of their time trying new agents. I can't think of a time where we've had more open and active trials at Johns Hopkins for people with more progressive types of multiple sclerosis. And I think what we're seeing is that we're learning a lot about the assumptions that we've been making about the disease course, the types of ways we're measuring how people get worse, and we're refining the way we do those trials to do each one a little bit better, which is half the battle in actually figuring out if a medication works. So I think all of that's quite exciting. Of course, that one of the hot topics for this year has been tolobrutinib. The FDA will be reviewing that particular medication in the fall for non-relapsing secondary progressive MS. So that's very exciting. I know I, as a clinician, am eager to figure out how we're going to roll out this particular medication because it does require quite a bit of safety monitoring that might be pretty challenging to implement in the real world, but that's one exciting medication that's coming up. Earlier this week, the vidofludimus calcium study read out as showing an effect in a small study, actually, in people with progressive types of multiple sclerosis. Usually when the studies are that small, people don't really expect to see a big signal in terms of preventing or slowing down disability. Usually it takes a much larger study, so that was a little bit unexpected, but sort of exciting to think about. And so I think, other medications, we heard about Dr. Weiner's study. There are many other things in the works now. So I think that's great. We're at Hopkins are trying to figure out how to study disability worsening better, and have a new way of doing so by using a wrist-worn watch, like a Fitbit type of device. And using that device over the course of about a year, we were tracking people's changes and the patterns of their activity, and we were able to predict within a person whether their MRI was likely to change after that, as well as whether they were likely to get more disabled a couple of years later. And this might really help us do these clinical trials better, so we'll know which people might be the most important to include in the trials, and also be able to measure if a medication is working a little bit more effectively, and then also to figure out which people in the clinic might benefit from starting medicines that slow progression before they develop those symptoms, rather than waiting for things to get worse and then saying, oh, maybe we should try this now. So yeah, I think I'm really inspired by all the work that's being done and a lot of collaborative work across these and many other centers. So the future to me is looking bright.
Thank you, Dr. Mowry. And next is Dr. David Hafler on new immunology updates in MS.
Thank you. Let me start by asking a question. Who here thinks we know the cause of multiple sclerosis? Anyone here think we do?
David, I do.
Thank you. Howard's my mentor. I train with Howard, so thank you on that. And of course, we never really know causality because you don't know what you don't know. So in my brief update of immunology, I'll contend that we actually have a pretty good idea as to a working model of what causes MS. And I'll present one bit of new data that suggests a model may be correct. So what causes MS? We think it's triggered by a virus called Epstein-Barr virus that targets B cells. That may be the juice, the adjuvant that turns on autoreactive T cells. We know there are autoreactive T cells in patients with MS that recognize myelin. We think they may be causing the disease, and it's related to a loss of regulation. There's something called regulatory T cells, which we and others have shown are defective. So what's the new update in immunology? How do we know our model is correct? Many of you have heard of the drugs that deplete B cells, Ocrevus, Kesimpta. And we've just completed an investigation that's going to be published next week. And you can look it up on something called PubMed. Put my name in, you can see the article there if you're interested. And what we discovered is that with B cell depletion, one has an increase in function of these regulatory T cells that are defective in MS associated with loss of autoreactive T cells in the blood. Now, does that prove that autoreactive T cells are causing the disease? Well, we don't do proof in science. We create models. But the fact that a drug that stops we call it relapsing remitting. I want to rename that. I think there are two stages of MS, the so-called autoimmune, where there are autoreactive T cells attacking the brain. And then there's the neurodegenerative form of MS, we call progressive MS. And the neurodegenerative form of MS, in fact, has similarities at an immunologic level with macular degeneration and Alzheimer's disease, where the nervous system itself becomes more neurodegenerative. And we're very, very excited about BTK inhibitors. And perhaps I'll end with the most important question in the field is if we stop the autoimmune component of the disease early on, and the earlier you treat, the better. The more aggressively you treat with effective drugs, the better. Do you stop the neurodegenerative progressive form of the disease? And that's the big question we're all trying to address. So again, the new update is we have more evidence that our model of autoreactive T cells causing MS is probably correct. Thank you.
Thank you, Dr. Hafler. And next, exercise and physical and cognitive rehabilitation and devices that can help. Dr. Vijay Yadav.
Hi, everyone. Good morning. First of all, I would like to begin with thanking Nancy, actually, for putting this symposium, and she's been doing that for the last 32 years, which is amazing, and, to bring this group of panel together. Thank you, Nancy, for everything that you have done to really make the biggest difference in the MS world, I think. The drugs which have come out, for example, the B-cell therapy drugs that came out, I think that was the collective effort of this group itself, which I'm pretty sure you remember Ocrevus. So I think in terms of exercise and its role in rehab in MS, there was a time when people with MS, when they were diagnosed, and I can say that maybe 20 years ago or so, people would be recommended not to do exercise because if you're feeling fatigued, just rest. And I think that's not the recommendation anymore, because there have been many trials, many studies which have been done that have consistently shown that exercise actually is good for MS. So just because some people can get heated and they feel a little tired after exercise, that's not the reason not to exercise. Another thing about exercise is the progressive MS specifically. In fact, yesterday we had a wonderful talk by one of our colleagues, Dr. Graves, who talked about how we can change the biological age with exercise. So, even though whatever your chronological age is, that can be changed by doing exercise and lifestyle modifications. And she showed some wonderful data showing that, we can actually become younger by doing exercise, and that would be applicable to patients with MS as well. Another thing to keep in mind with progressive MS is as people become worse with their disability, they start to become lesser and lesser active physically. And I think that's the wrong thing to do. In fact, when we are aging, there is a term called sarcopenia, or loss of muscle with aging. That's a very real issue that affects everybody, no matter MS or not MS. And if you stop exercising because of that, you will add up to the progression of disability. So I think definitely anybody who has any kind of limitation, with weakness and all, there are therapists, the physical therapists, occupational therapists, they are the professionals who will really help you in getting the right type of exercise to do that. And there are some stimulation devices also available, and I think the future of neurosciences, including MS, is really in neurostimulation. We have done a very good job of controlling relapses, as Dr. Weiner said, and I think progressive MS, we do not have very effective treatment right now, but the exercise and all those are strategies, and stimulation of the nervous system will be strategies that would probably prove to be much more beneficial in long term. How we will get there, there are very small steps. I do not want to go into too much detail here, but clearly working with the professional therapist can tell you which devices might be the right for you. Thank you.
Thank you, Dr. Yadav. And next, Mark Parandis is going to discuss his experiences with MS.
Good morning, everyone. Is this on?
I think you're good, yeah.
Yep. Is that good? There we go. Thank you. Good morning, everyone, to the doctors, to all my fellow MS warriors in the room, and to most importantly, to all the loved ones that are here with us, both in the room and online, that support all of us. We're all going down this bumpy, winding road, which has been given the name multiple sclerosis. I've fought alongside of all of you in this relentless battle for, it's incredible, 25 years now for me. And I have to tell you, I used to give these talks without making reference to my notes, but as my kids will be the first ones to point out, now that I'm senile, and for other reasons, I'm going to ask your indulgence while I look down at my notes just during parts of this talk. So during the last quarter of a century, I've celebrated many of the hard-won victories of the disease-modifying therapies like Chad talked about courageously last night. But at the same time, I've dreaded the mornings when my own legs have refused to obey my brain, when I lose feeling on my entire left side or on my face, when I have the stabbing pain that feels like somebody's taking a knife and just going right into your legs. It hurts. It does hurt. And I have empathy for everyone in this room and around the world that has to experience these pains, because despite my facial disfigurement, I look okay, but that's not necessarily how I feel. However, I have to point out that every breakthrough that has been made by the people that are here in this room has given people like Chad, myself, and others that I've met this morning to enjoy more time in the sun, more time to live. But each one of those opportunities has been granted as a result of work born in a laboratory, nurtured in a clinic, and paid for by public and private research dollars. These aren't just scientific advances, they're lifelines. They're what give us hope. So first, let me just ask everyone here this morning to join me in a round of applause to congratulate all the doctors around the world who are devoting their incredible intelligence and energy to finding a cure. Your dedication, and I say this to all of you sincerely, gives us hope, and we're not going to stop until MS is defeated. So while I said that I was going to talk about my MS experience, what I'm really going to do is deviate, as only a lawyer would do. You say one thing and then you do something different. So I want to talk for a minute about funding cuts. Today in the room, we have some of the most important bastions of medical care in the world present, whether it's Johns Hopkins, Harvard, Yale, and everyone else. And it's the work that you're doing which gives us the hope that we need. But now, unbelievably to me, and I emphasize unbelievably, the National Institutes of Health, their funding is being cut tremendously, and it feels like a real punch in my gut, and probably in yours as well. Recently, at the NIH, there's been about $2.7 billion in cuts made. There's been $1.8 billion in grants no longer funded, and now there's an $18 billion proposal to cut the NIH budget. That's 37% of their budget gone. So I have to tell you that when these budgets shrink, the pipelines to our treatments grow quiet. Promising trials stop. And unfortunately, the next generation of neurologists may actually drift into other areas which are more well-funded. So in our race to erase MS, every delayed experiment is a misstep. And for those of us whose mobility is already affected, That's unacceptable and intolerable. We cannot allow research for a cure to become a political football. The fight against MS and all disease must rise above partisanship. Medicine should not have political parties. There's nothing Hippocratic about that. There's no Republican or Democratic disease. The only side we should be on is on the side of science, compassion, and progress. All of our lives depend on this. So while our researchers are closing in on the biomarkers that can predict progression before a single symptom appears, or remyelination therapies that might restore function rather than merely preserve it, on tools that really sounded more like science fiction than anything else, there is a scientific blueprint that exists. What's missing is the sustained investment that transforms blueprints into cures. We have to demand that the pursuit of cures remain above politics and that the health of millions should never be sacrificed for political gain. I'm going to encourage each one of the people in this room and listening on the web to ally with organizations that are already in the trenches, especially the Race to Erase MS, founded by our incredible Nancy, whose tireless work makes a critical difference in our fight against this disease. I urge every one of you to volunteer for MS advocacy groups, to share your stories on social media, and sign every petition that you can that lands in your mailbox to support our cause. I'm also going to encourage everyone, to the extent that it's possible for you, to participate in local clinical trials, not merely by enrolling, but by championing their importance within the hospitals and within our community. Every action, no matter how small, is a small spark that can invite change. It's important that we understand that we're more than a patient population. We're a movement, a constituency, and constituencies can move mountains and budgets. Before I conclude, I just want to share two more things. First, I want to congratulate my son Alec, who I believe is watching online right now, who's going to be running his very first marathon tomorrow in Denver, and we're going to get a bagel afterwards, Howard. We're very proud of him, and I apologize. I'm literally, as soon as I finish, going to get up so that we can go to the airport to fly to Denver to watch him cross that finish line. Second, I want to recall something that I said from this dais 2 years ago, when I explained to everyone, and this is crazy that it's already been 2 years, that Nancy had driven me and my beautiful wife Rose to the Cedars emergency room, as even at that point in time, the slightest touch on my skin would cause unbelievably agonizing pain. Luckily, today, for the last couple of months, I haven't had that pain at all. But you have to remember MS. One pain gone, another one comes. MS is a very perseverant disease. It doesn't give up, and that's why we can't give up in what we're doing. So I have to tell you that we need to keep working, we need to drive forward, and remember that our resilience is our greatest weapon. We are going to, with the help of all of you, win the race to erase MS. Thank you.
Thank you so much, Mark. We appreciate what you've just told us. Thank you. And next, Dr. Emmanuel Wabant is going to talk about long-term risks, efficacy treatment for MS, including risk of cervical abnormalities.
Good morning, everyone. And it's a difficult act to follow Mark. Yes, it is. And I think you said in beautiful words what most of us had in mind. So thank you for doing that. Thank you to Nancy also for relentless being our MS warrior and supporter of the science. We had an amazing scientific day yesterday. I'm the medical director for the group, and it's always completely overwhelming to see so much mind power, excitement about research, very constructive and sophisticated discussions about how to improve the research that each others are doing to advance ultimately the care of patients who have MS. So thank you to all the doctors, all the different generations of doctors. Yesterday in the room, I asked, how many people in the room? So we were about 35 in the room, and I asked, how many people in the room have had young investigator funding from the Race to Erase MS? And out of 35, there were 7 people who raised their hands. Some of them gave a talk, but they're still sticking to the field, right? So we've been able to foster the next generation, and we hope to do that for the longest time because that's really critical. I don't want, when I retire, to have nobody to take over. I want many more than me to continue the fight. So the topic I have to briefly touch on today is the long-term risk of high-efficacy treatment. So as you know, for the past, I would say, 15 years now, there's been what we refer to as high-efficacy treatments that are super effective at preventing flares of MS and new scars on the MRI. This has radically transformed how well patients do on treatment, especially if they are treated early. But it comes also with a cost for some of the patients, and I think that the clinical trials address the overall short-term safety of these medications because the treatments are usually given during 2 to 3 years in clinical trials. There's often extension for a couple of years, so safety is better understood. But what really helps is studies that are observational studies that are capturing large cohort of patients in different parts of the world, identifying what may be rare side effects or side effects that may occur with longer exposure to some of these drugs. So I think that the first kind of concerning side effect that we discovered was with Tysabri. It was the PML, so the slow brain infection. So that one is a classical, and we know how to prevent it. We know even how to treat it. This is a rare complication that can be seen with a couple of other type of treatments, but less frequently. What's been a concern over time is, are some of these medications increasing, for example, the risk of infections? And there are now studies that are suggesting that some of these medications, like the anti-CD20 agents, so Ocrevus and all that family of medications, possibly the S1P modulator, so fingolimod and the same family of medications, can increase on the long term infections in general. So the increase is not huge. It's not a reason to not use these drugs. But in specific patients, more notably older patients or patients who have advanced disability and already a baseline risk of having recurrent urinary tract infections, for example, it can become an issue. And kind of modulating how we use these medications can actually help prevent these infectious risks. The other question has been also, are some of these medications increasing the risk of cancer? Because when you downplay the immune system, some of what can happen is an increased risk of cancer. So we don't see much of that in multiple sclerosis, which is good because the medications we're using are really not what people would think about as chemo, except maybe a couple of them. So we don't see a major increase in the risk of cancer. I would say the exception is with the S1P modulators. There's an increased risk of skin cancer, so fingolimod and all that family of drugs. One need to go have a skin examination once a year to make sure that there's no brewing skin cancer that is developing that is a known phenomenon to happen a little more frequently with those medications. And more recently, Claudia brought my attention to something that had never been really studied. And this was studied in women who had been on medications like high efficacy medications such as anti-CD20 medications, so Ocrevus and the like, or natalizumab, so Tysabri, or S1P modulators, so fingolimod and the like. And it seems that there's a credible increase in the risk of cervical cancer, or at least in the risk of changes that occur at the bottom of the uterus of women who have been on these medications longer. And we think it's related possibly by decreasing the ability of the immune system to fight a chronic infection, for example, with papillomavirus. So there's a recommendation from that recent publication to have women who have been on this treatment for a while to have more attention from their OBGYN. So, these are definitely not side effects that would prevent us from using those drugs. It's just putting on our radar screen how can we manage safely the use of these medications from the long term. So that's all I had to say. Thank you for being here.
Thank you, Dr. Wabant. And next, Dr. Ron Navasco, sex differences in susceptibility and progression in MS and treatments.
Hi, so I want to talk about some really big picture things in MS. There are a couple things that we know, and we can really learn from them. We can come up with new treatments based on learning about them. One of them is actually aging is bad for MS. We heard about this yesterday. We've known this a long time. That's when people go from relapsing remitting to progressive MS, when they hit about 50. What else do what's a big picture thing that we could learn about? If we understood it, maybe we could fix it. There are sex differences in MS. Why do we care? Well, if we understood them, we might be able to change them and come up with new treatments. What are those sex differences? Well, there are two phases of disease, as you've heard, the relapsing remitting phase, the inflammatory phase. This is very interesting because autoimmune diseases in general affect not only MS in women more, but also lupus, rheumatoid arthritis. All these autoimmune diseases, most of them actually affect women more than men. Why is that? Well, there's evidence that having an X chromosome gene, women have 2, men have 1. There's an X chromosome gene that may be contributing to this propensity for women to have more susceptibility and relapsing MS. So that it's 3 to 1. We know that. Women have MS more frequently than men. Why is it? It could be this X chromosome gene. What would we do to treat? We'd come in and we'd try to reverse that gene, right? So you can see how an observation can lead to a treatment. The other thing that's interesting about MS, as you know, it's got a progressive phase. That's the disability phase. That's the neurodegenerative phase. And that's different. The sex difference is different. Men actually do worse with disability progression. But it actually is at a certain time, and that's when you look at men that are about age early 40s. Actually, when women go through menopause, they do worse with their MS disabilities. So this is very important. There's a sex difference but in degeneration, but it varies based on the timing. And sure enough, testosterone with andropause, estrogen with menopause, they have different timing, right? Menopause, we all know what happens at age 50. It's pretty bad. Estrogen goes from very good to very bad real fast. What happens with men? Well, you guys are not out of the boat because testosterone drops by 1 to 2% per year from the age of 30 to 70. It's a slow, slow, slow decline. So if you look at people that are around those early 40s, actually, men are starting to lose their testosterone. That's neuroprotective. And women are doing okay yet. They haven't hit 50 yet. So men are worse. But what happens when you're about 55? All of a sudden, women have crashed with their estrogen, and they do worse. So the point is, if we can figure out why, that might be why aging is bad for MS, right? Maybe it's loss of these neuroprotective hormones, estrogen in women, testosterone in men. That's one concept. There could be other things about aging too. The point is, if we can take these major things that we know a lot about. They're like gifts, they're like clues. If we could just understand them, we can come up with new treatments. That's it.
Thank you, Dr. Voskuhl. So next is Dr. Nancy Sykott. How safe is it to stop MS treatments, including pregnancy and other patients, and older patients, I'm sorry.
older patients. Thank you, Claudia, and thank you, Nancy, for organizing us again and bringing us all together. It's so fun to see our colleagues from across the country and catch up in a small setting where we can really talk about the work that we're doing and brainstorm ideas and kind of stimulate each other's work that we're doing. So thank you for keeping us going all these years, Nancy. It's really important. So I've been doing MS for a while, speaking about older. I have a whole cohort of patients I've been following now for about 25 years, and we're all growing old together, which is really interesting to see. But I will say during the time that I've been practicing medicine and taking care of MS patients, one of the biggest changes I would say has to do with women who have MS and pregnancy. When I first started, I had a mentor who was an older person who would advise his patients once they were diagnosed that they should not get pregnant. And that was pretty common, which is a little bit shocking probably for our younger trainees now to recognize that. But just like women were told to stay home, women were told not to have children, in part because of the postpartum relapses. As it turns out, pregnancy itself is good for MS, and Dr. Voskuhl's done a lot of work on that, showing, and other people have showing that relapse rates actually go down during pregnancy, but they tend to go up in that postpartum period. So that was one of the things that made physicians tell women that they shouldn't get pregnant. So it's a new day, and this is one of the things that is really rewarding to see our patients when they're first diagnosed, that we can have this conversation with women patients about their fertility and about their family planning. And I make a joke when I'm first meeting a patient, I say, I'm going to be like your mother. When are you going to have kids? And in part, that's because it depends on when we're picking a disease-modifying therapy. If they're really thinking that they're going to want to have a pregnancy in the next 2 years, it affects the drugs that we choose. And part of that has to do with this stopping of the medication. So there are certain medications that have what we call a rebound effect, which means when you stop them, the disease activity can go up and be worse than baseline. It's rare, but there are two classes of medications where this happens. One of them is natalizumab or Tysabri. Well documented that when you stop the medication abruptly, you can have a rebound relapse. The other is the S1P inhibitors like fingolimod. So those would be two drugs that we would not recommend that women use when they're pregnant. But in terms of other ways to approach pregnancy, because of these new therapies we have, these B-cell depleters, they work for long periods of time, and so it provides an opportunity for women to be protected from disease activity while they're trying to get pregnant and during pregnancy itself. And one of the exciting things, going back to what we heard from Dr. Hafler about changes in B-cell reactivity, it does seem as though those postpartum relapses are maybe less likely to occur in women who've been on these B-cell depleters for a period of time before they get pregnant. So there seems to be less of this postpartum relapse activity. Certainly, anecdotally, we've seen that in our practice. So in general, we don't recommend that women continue their disease-modifying therapy when they're pregnant. They haven't really been tested during pregnancy. There are some brave individuals, some other practitioners who do use some of the therapies in their patients, and that's a very off-label and personal decision that folks make. But what we know now during the postpartum period, even with nursing, that most of the medications are safe to use. So that's another really nice change that we have, that we realize that the drugs can be used during nursing. Very little is passed through the breast milk, and folks can get back on their medication even though they want to continue to breastfeed. So we really have seen a little bit of a baby boom, I would say, in our clinic at Cedars, and it's very exciting to see folks live their best lives, which is what we're trying to do in our MS care. On the other side, the other area has to do with older patients stopping their medication. So a bit of a luxury, right? We didn't have any therapies to start, and now we're talking about, well, how long do you have to actually take the medication? We don't have great data to support us here, but we do know that there are many patients who get past that 50 and 60-year mark, and they're doing quite well. They've had very stable disease, their MRIs are not changing, and so then the question becomes risk and benefit of some of the therapies. We heard about the infectious risk, and those things tend to be more pronounced in patients as they get older. And we know the immune system is less inflammatory with age, maybe more neurodegenerative. So there have been a couple of studies. There was a study called the DISCO-MS where they discontinued medication in patients, but it's complicated because, in part because of this rebound effect that I was explaining. Certain drugs maybe cause this increase in activity that the other drugs did not. So we're really waiting for some biomarkers that will help us really make this decision. And right now, it's a very much of a personal decision, individual decision with your practitioner, and we regularly are having these conversations. So when infection risks are going up and disease activity has been very stable, this might be a time when you make a decision to stop medication, but we continue to monitor clinically and using MRI to make sure that there's not an increase in disease activity afterwards. So we're looking forward to having some better tools that we could use to identify those patients who can safely stop their medications versus those who should stay on. So lots of progress to come. Thank you.
Thank you, Dr. Sykott. And next, Dr. Christine Azevedo, new MRI markers and MS diagnosis and prognosis.
Thank you, Claudia, and thank you, Nancy, as always, for everything you do. Thanks to everyone for being here. It's such a pleasure to be here, always. We've had a lot of great developments in the MRI field that I think are really exciting, and I think I'm going to borrow a technique from Dr. Hafler and ask a question at the first part to say, I wonder how many people here felt like they had a long diagnostic journey, where it took a little bit of time to get to the right diagnosis. And I'm seeing some, oh wow, okay, lots of nodding and hand raising. So we really hope to shorten that. And so we hope that MRI, which as you guys know is a huge advancement in general, so there was a time back in the day when the old test for MS in the 1950s and 60s was called the hot bath test, where they would just place patients in a hot bath, and if they got worse, they diagnosed MS. So fortunately, we've evolved. MRI has helped, and in the newest version of the diagnostic criteria, we're hoping to evolve even more. So the newest markers that we're talking about are things that use iron-sensitive imaging, and there's two techniques I'll mention. One is called the central vein sign. So this is based on a long observation from like 2 centuries ago that MS lesions like to form around blood vessels. And so now, which contain blood, which contains heme with iron inside, so now using these sort of specialized imaging techniques, we can see the blood vessel inside the lesion, and that gives us more specificity that it's probably a demyelinating lesion. So in some cases, it can be really confusing. As you guys, I think, know, the diagnosis is not always straightforward. And that's part of why it takes time. And unfortunately, sometimes even errors are made where there's a big literature in our field about misdiagnosis, which we absolutely want to avoid. So we always want to diagnose early, but we also want to be correct. And part of it is that many diseases can cause white spots on the MRI scan, right? So you can have migraines, sometimes with age, there's small vessel disease from vascular disease and so forth. These cause white spots, but they're not demyelinating, and we don't expect them to be around blood vessels. So using this technique where we can line up the white spots with the blood vessels, we can be more certain that the white spots we see are in fact demyelinating. And that's really helpful. That's been incorporated into the newest version of our diagnostic criteria, which are going to be published. We revise these every few years in the field. And the newest version should hopefully be published in the next couple months, I would hope. It's been a long story, but yeah, there's been a delay in the publication. But we hope that'll come out soon. And so the central vein sign should be used not only to help diagnose MS patients, again, to lead to a more early and accurate diagnosis, but also, there are ways we could use this to monitor MS along the way. We've talked about aging. Let's say somebody's in their 50s or 60s and they develop a new white spot. We're going to have to ask the question, is that an MS white spot or is this an aging spot? And a central vein sign within that lesion could be very helpful there. So I will just also mention Dr. Sykott, who's sitting right in front of me, and other colleagues at Cedars and Cleveland Clinic have really led the way here. The pilot study for one of the main studies that's currently looking at the utility of the central vein sign in making the diagnosis was funded by the Race to Erase MS. So this is a huge advancement for us. So I want to just pause and applaud. I don't know, Nancy, you remember the CAVS MS pilot study? So that came. Now there's a much bigger study funded by the NIH that's really seeing this through. The second imaging marker is called paramagnetic rim lesions. This is a little bit of a longer story, but essentially same thing with iron-sensitive imaging. Essentially what happens is early on when lesions form, there's a sheet of inflammatory cells, right? The inflammatory cells get activated in the bloodstream for reasons that we still don't fully understand, maybe Epstein-Barr, maybe other things. They cross into the brain, they cause lesions to form, and there's a bunch of inflammation. If you look under a microscope, there's a ton of inflammatory cells inside those new lesions. Over time, in most of the lesions, the inflammation will clear out and you'll be left with a scar, which is where the multiple sclerosis, multiple scars, right? But in a subset of the lesions, it'll remain around the rim, there'll be this chronic, low-grade, what we call smoldering inflammation, where there's some inflammatory cells around the edge and it looks like they're still kind of slowly causing tissue damage and demyelination. Some of those will have iron inside, and again, because this iron-sensitive imaging, we can now see, with fancy techniques, we can see lesions on the MRI that have rims around them, and that tends to be more associated with progressive forms of MS. So we are starting to understand this better. We're hopefully, this is still something that I think is done largely on a research basis, maybe at academic centers. Of course, a big piece of this is trying to disseminate these techniques to the community so that all patients will have access to these kinds of techniques. But seeing these rims is going to, I think, be a very important aspect of the next phase of our treatment and our care for patients. And I think, as we've heard, especially in the context of the field's focus on developing new therapies for progressive MS, we have a lot to learn here, but watching these rim lesions go away might be something that is important for us in the new phase of the next sort of generation of treatments. So very exciting work. Rim lesions.
Thank you, Dr. Azevedo. And next we have Dr. Adam Kaplan, Health Information Technology and Mental Health.
Thanks so much. Appreciate it. I'm actually going to change my topic only because I've changed my job in the last couple of months. So I've started co-founded a company called MyNerve, which is a company that is going to cure Alzheimer's disease. No problem, right? Easy. So what am I doing in Alzheimer's disease? Well, Nancy had the forethought of making centers without walls, but what is also inherent in that is that not only are the centers without walls, but the problems that we're dealing with have other implications to other conditions. So really, I will tell you that the work that I'm doing in Alzheimer's comes from the work that my colleagues and learning from these other centers are doing in multiple sclerosis. And what I'm going to do is just follow up on Dr. Hafler's discussion about what is MS. Before I do that, let me just explain why that's so important and why I'm so pleased that he set me up so well, is that my girlfriend is here, and when we went out on our first date, I said, don't you want to hear about this new company that I started? And she said, no. I said, really? She said, yeah, no, I don't care about your company. I care about you. What kind of person are you? And so I really think that the same thing actually applies, that we should all care about, understanding this disease and what is this disease. And so what I loved what Dr. Hafler said was that he characterized this as one disease, right? That you have inflammation going on early. It strips the myelin, which is like taking the rubber off of these wires, strips the myelin off the neurons, And then later, there's a downstream consequence, which is this neurodegeneration. Interestingly, he cited Alzheimer's as an example of this neurodegeneration, which is what I'm going to end with, because that's what I'm saying we've learned here. And what's really critical to understand is that many people, I think, have gotten a little confused about this being two diseases. One is inflammatory and the other is purely degeneration, as though the wires themselves are the problems, not the earlier inflammation. So that's really important to know which one that you're dealing with. It's like saying, gee, there's mice that are running around and chewing on the wires. The wires then rust. Let's either deal with the mice or deal with the rust as a separate problem. So let me just explain why I will maintain that this is one disease that has two components, as Dr. Hafler nicely illustrated. First thing is that we've had a 50% reduction in progression to secondary progressive MS, meaning that if you go back before the 1990s, 50% of people, 1 in 2 people, ended up in this secondary progressive phase where they get worse and worse without new attacks. It's this degenerative process. And we would tell people they'd end up in wheelchairs in just a matter of a decade, 50% of people because of that. Now it's cut in half. 25% of people with relapsing or remitting will progress to secondary progressive within 10 years. And that's because, one, we're treating it earlier. So treating within 2 years of the diagnosis leads to decreased progression by 50 to 70%. The other is that these new powerful drugs, which yes have side effects, can make a huge difference. So when I joined the whole MS battle, we had Copaxone and interferon. Copaxone's 30% effective at decreasing new relapses and 30% effective at decreasing new lesions. That's like me telling my patients, I'm going to get you out of bed with the depression 30% of the time. The other 70% you're going to still be there, and I would be out of a job, because who would come and see me with that kind of response? So now we have ocrelizumab and other powerful treatments where the relapse rate is decreased by 60%, new lesions by 94%. So the other thing is that ocrelizumab, which affects B cells, inflammation, decreases disability progression by 25% in patients who have relapsing remitting MS. And if you look at those people in the highest quartile who had the highest levels of ocrelizumab in their serum, it was actually 66% decrease. So again, hitting the inflammation decreases that. The last thing that, and I think this is the most important thing, is that bone marrow transplant is dangerous. So I'm not saying rush out and do it. It has somewhere between a 0.3 to 3% mortality rate. That's a bad side effect, to have death as your side effect. But having said that, we know that those people who go into treatment have severe MS, and people who had bone marrow transplant, which Dr. Weiner and Dr. Hafler worked on this kind of paradigm early on, and were some of the early people doing this work. You take patients who have an 80% chance of progressing, having this progression, this worsening course without inflammation, and you flip it on its head. Now, 80% of people after a bone marrow transplant will have long-term stability without any progression. So when we say we don't have any treatments for progressive MS, it's not quite true. We do, it's just a really dangerous treatment. But the point is that if we do make a thought about this, it really is the inflammation, leaves the wires open, they rust, and if we can understand that, we can understand this disease better. So treat early, treat aggressively. That's the take-home message. The other thing is that we'll only cure MS if we understand it truly, and so I think the data is very clear that this is one disease, not two. Last thing is that, interestingly, turns out that Alzheimer's disease is not so very different either, that there is an inflammatory component, and if you can shut that down, you can shut the Alzheimer's disease down. The question is how to do that. And I'd tell you, but I'd have to kill you because our company's just getting off the ground. So in any case, I think it's very important to realize how important it is that this Center Without Walls, this gives us a chance to also have diseases without walls and to understand better how to approach these things in general. Thanks.
Thank you, Dr. Kaplan. And last but not least is our very own Chad King.
Hi. First off, thank you. Thank you for having me. Brilliant minds over here, and it's amazing that I'm here too. This is so cool, you guys. Okay, thank you. Can I ask how many of you have MS or yeah. Me too. Okay. That's amazing. I feel like I belong. So thanks. Yeah. So I was diagnosed with MS, relapsing remitting MS, when I was 21 years old. I was senior year of college, and I think it's an interesting story. But I had just come out to my best friend as gay, and I was like, I'm gay, and it was like, oh, I felt so liberated. And then within 2 weeks of coming out, MS symptoms started popping up, and within 2 weeks after that was when I was diagnosed with MS. So I feel like I came out, but then I didn't really come out because I had, and then anyway, but I had a choice. I was like, do I tell my parents I have MS, or do I tell them I'm gay? And so I decided just to tell them I had MS, and I didn't tell them I was gay. They know now. They know now. So it's been a journey. I said last night too that I sort of ignored the diagnosis, and I sort of just kept going about my life as if no one said anything to me, and it was amazing to do that, but also it was kind of scary decision on my part, because symptoms would pop up here and there. Like there was a live TV performance that we had to do, and during the performance, while I was singing, like at a high note, it was the first symptom that I ever experienced like this. But I was just singing a high note, and then my speech started to slur during the performance. It's the first time on live TV, and I was taken aback, and I didn't know what to do, and I was like, I don't know, just trying to get through it. And Ian was performing it with me, and he like recovered and helped me. He saw something strange was going on. So anyway, so things like that would pop up, but then things like that would disappear, and for years that would happen, and then nothing really stayed, and so I didn't think much of MS. I mean, I tried to like manage it as much as possible, and I did, and then it wasn't until, like I mentioned last night, it wasn't until about 4 years ago that things started to really change. And what was going on in my life then was that my dad had just passed, and I said 4 years ago. My dad passed 2.5 years ago. But sorry. Okay, so my dad passed, and then chronologically, I gotta figure that out. But my dad passed, and then I got COVID within 2 weeks after that, and that's when my walking started becoming impaired. And that's also when I decided I was like, okay, MS is really affecting me, because my studio that I work out of was only half a mile away from my apartment, and I couldn't walk it. And that's when things really started to change for me. But I thought something else that was really interesting. And then I got an Ocrevus, which saved me and stabilized me, and it's been amazing for me. And then, I spoke to some other doctors. I don't know if I want to call them out, but spoke to some other doctors that actually helped me find some strength again on the left side of my body, like I mentioned last night. I was able to play guitar again. Last night, you guys, I thought I would never be able to play guitar again, and last night I did. That was a first. That was truly a first moment. I didn't think I could ever get to. After it's been a few years that I was like, okay, I guess guitar is not in my future. I guess singing is not in my future, and it felt like for a big portion of this chapter was me kind of coming to terms with feeling at peace with the idea that my dreams were changing, and I had to be okay with that. And this dream that I had, these life plans that I had, just couldn't be that. And so something like last night, I'm getting emotional. Something like last night was really, really profound for me, and thank you for experiencing that with me. And I mean, just to say that, dreams can change, and I embrace that, and I embrace it fully. But I also embrace the fact that they can change in the best of ways for you. And this, what a beautiful story and journey this has been, to go from okay, I'm gonna be on top of the world, to okay, I'm not. I'm actually gonna be at the bottom, to now it's like an upswing again. And so I know that MS is so challenging for all of us, but also we have to find the silver lining. We have to find the beautiful moments like that, because this is gonna be an uphill battle, or up and down journey. And I wish you all so much luck. Thank you.
Thank you, Chad. And I wish all of you had been here last night to listen to his very meaningful and personal and song that he wrote.
Chad, would you by any chance want to just say a few of the lyrics in the song that you wrote about MS? I just think it's so motivating.
It was
a lot of people
beautiful.
might not have been here last night.
The first verse is, my hands are not the same, my voice is not the same. These days are different for sure. Another verse is, it's hard to believe it's true, a life that I thought I knew, these days are hard for sure. Dreams going out of view, watching my life in two, yeah, these days are different for sure. But the hook of the song is, I know it won't be long, that all in time moves on. So it's all gonna be okay. It's all gonna be okay. Yeah.
Just to say very briefly, last year when Chad came and he did sing, he was having some struggles. And right after we had this exact thing, I made him go to lunch with a few doctors, and he got on a very good path of medication, and he has improved so much. And it's just amazing to see you now versus then, and the song you wrote and how inspiring you are to everybody. So I'm so glad you're here.
Thank you. I'm glad. Thank you. I'm grateful.
Yes, when will we be able to download that song?
Well, I thank you for asking. It's on my mind too. I would love to record it, and I'm planning on recording it. I just don't know how fast it's going to be, but yeah, I would love to record that one.
Thank you, Chad. All right, the most exciting part of the day is the lightning round to answer collected questions. So I'm going to turn it over to Emmanuel to tell who's going to.
Okay, so there were questions that were distributed in advance. So I know, Dr. Sykott, you have a couple of questions if you can address.
Absolutely. Thank you, Dr. Wabant. So I got a couple of MRI questions. That's the other area of my research interest. So one of the questions was, all this talk about contrast perhaps causing issues with patients when they do their MRIs. How common are the issues with the contrast? I've been doing them for more than 2 decades with contrast at least once a year to monitor progression, relapses, rebound, and see how DMTs and steroids are performing. So the bottom line is gadolinium, which is the contrast agent that we use for MRI scans, is very safe. This is a compound that's been used, that's been used for decades in extraordinarily large numbers of patients without consequence. There is a very rare syndrome associated with renal failure, where if you are given contrast, you could develop this deposition of the gadolinium in your skin and other organs. Again, extraordinarily rare, and now we screen very carefully before people are given contrast agents for renal function. Secondly, the newer contrast agents, this is a very sophisticated question, are designed so that they are less likely to deposit in the body. So the older ones would separate under certain conditions, and the gadolinium could deposit. The newer agents, that's not an issue. So, but the truth is, a lot of us who do MS are using less contrast, and that has to do with the fact that we have pretty good MRIs that we can use from year to year to do a comparison. And because, truthfully, the inflammatory activity is very low these days, given the therapies that we're using. So it's rare that we see new activity on MRIs, just because we have such great therapies. But if there's a new symptom, then that would be an indication to use gadolinium in particular, and at the time of diagnosis, and also to, if there has been a relapse, to monitor if the relapse has resolved. Those would be the indications for using it. But many of us are not using it on an annual basis, even though we're doing MRIs.
So I want to interrupt because there's something fun about that, right? You and I wrote an article many years ago. Do you believe in GAD?
Well, our trainee wrote that, as you recall. Yes, do you believe in GAD? And we do believe in GAD, but only in certain circumstances. Don't quote me on that. Yes. Okay. And then there was another question about gadolinium. Do MRI centers use the less harmful version of gadolinium everywhere now? And I would say the answer to that is yes, because of that issue. Another question I got, which is a great one, how has AI helped advance your research over the past year? So this is very exciting. Again, we're doing imaging research, a lot of that at Cedars with Pascal Satie, who runs our neuroimaging program, who's championed the central vein sign. But one of the issues is all of you who had your MRIs done, laying in that scanner and listen to the banging go on and on is a form of torture. It's like being buried alive with a jackhammer going over your head. I've had MRIs, so I know. But the AI is going to allow us to shorten the time of your scans incredibly. And Dr. Satie and his team have come up with a 2.5-minute scan that has the equivalence of an 8-minute scan. So what the AI is doing is looking at old scans, taking that data and interpolating the pieces that you get from the 2.5-minute scan and creating an image. Now, I can't explain to you exactly how that happens, but I've seen the images, the comparisons, and they're really exciting. The other thing AI is helping us, you heard about the central vein sign. It's sometimes laborious to go through and look for each of the lesions and identify the central vein, so AI is actually helping us pull out those lesions that have a central vein and pop it out for the neuroradiologist to have a report. And in fact, I just want to make a plug for Dr. Satie. He's at the ASNR now, which is it's the meeting for neuroradiologists. So he's now taking this central vein sign, the work that Nancy has championed through our NAMES cooperative, and is presenting that to the neuroradiologists so that they will understand these new biomarkers, because at the end of the day, the neuroradiologists have to buy in and write those reports to help us make the right diagnosis. Okay, the last question I had. Do you try quantum dots technology for work on strength? I don't know, proprioception and painkiller. I actually don't know what quantum dots technology is. Do any of my colleagues know what that is? I'm so sorry. So I would say no, I don't. Thank you.
Okay, so there were questions also. I think, Dr. Azevedo, you had a few questions
Yes.
related to imaging also.
Also some imaging questions. So one of them is regarding the iron rim lesions. Are there a lot of centers performing basically imaging with those, preferably with the 7 Tesla MRI and smoldering MS, who's now doing them? So great question. Whoever asked this knows about MRI field strength. So that's the strength of this magnet. So if this rings a bell for anybody, 1.5 and 3 Tesla is what you're used to probably having in your clinical scans. That's standard of care. Certain centers have 7 Tesla MRI scanners, which is a stronger magnet, which we have one at USC. And with that stronger magnet comes better resolution and better ability to see a lot of things. And so a lot of the work, in fact, Dr. Sykot mentioned Dr. Satie, our colleague, who has done a lot of the work at 7T to really see these lesions and the central vein sign. So long story short, 7T is super useful to see these things. Not everybody has a 7T, though. It's a bit of a rare resource, even around the country. So you can see these at 3T if you do it correctly. It's just, as I think we've said, it's just a matter of disseminating the techniques and the knowledge to the neuroradiology community and even to neurologists. I mean, even among ourselves, we're starting to see training modules so that we also can understand how to read these correctly and really use this the best. So I hope that answers the question. There's another question somewhat related. Is using contrast on an MRI, does using contrast on an MRI aid in seeing the blood vein for those who do not have access to the higher powered MRI? So good question, even at 3T, 1.5T. So contrast to see the central vein does help, but you can see them even without contrast. It's just with contrast, you have a little bit better detection of the central vein sign. And then last question that I have, will there ever be a study where they monitor male Hispanics progression while using the 7T MRI? And the short answer is yes, we sure hope so. Again, at USC, because we have the 7T and we also have a special expertise in our center with Dr. Roman, who's in the back, and my other colleague, Dr. Amezcua, who's not here, a large focus on Hispanic MS. Yes, we absolutely hope to do that.
Thank you. So Dr. Maury, you had questions also?
Yes, thank you so much. I have a couple of questions related to artificial intelligence, looking at whether AI, as it were, could help people understand, what happens when they're doing trials of various medications, and can we use AI to maximize effectiveness of various medications and their doses? And then secondly, could AI help us to understand better how different studies correlate and help identify gaps for new studies? And I actually wear a second hat at Johns Hopkins in helping to lead our precision medicine effort and led a symposium this week that was focused on AI in research and clinical trials. So I feel like this is a pretty fresh topic. There's a lot of really cool and exciting work sort of putting together AI and machine learning with medical care and research. And one of the things that we learned from our guest speakers that's, I think, super fascinating is that, the more ways that you can follow people, the different types of data that you can get, the more diverse the data are, the better the quality of these models is. And in fact, really kind of emphasize that diversity is more important than the quantity of data or the data points. So that I thought was a really helpful tool. The major theme that still emerges, though, and this is relevant, I think, to MS and where AI will play a role, is that when we're trying to use these techniques, it really relies on having excellent, systematic, high-quality data in order to feed the statistical models. And so what that looks like is standardizing the way that we follow people in large scale, both with respect to how are we capturing what people are feeling, how are we capturing relapses, how are we capturing worsening of disability, how are we capturing MRI and biomarkers. And traditionally, that really hasn't been well enabled at scale in our electronic health records. Those are set up for care and things like that, but they're not really necessarily aligned with also a secondary purpose of conducting research. Whereas now I think that clinician researchers in MS and other things are really working to do more systematic data collection. I think some of the challenges, because we've been doing this for several years at Hopkins, I think it's really important to think about how are we going to make sure that when we're doing that systematic data collection, that the people we're collecting data on are representative of those with MS more broadly. What we don't want to do is have good quality data collection on some people, but other people are left out. So hopefully that answers that question, but I think there's a lot of promise. And then the second question is a little bit more personal. My daughter was diagnosed with MS in 2008, currently taking Ocrevus IV, looking to switch to the new subcutaneous injection. Tell us a little bit more about that. Yeah, that's really a nice opportunity to be able to have different types of administrations of our medications. There are many different products of these anti-CD20 therapies, luckily, and one of the advantages of using the subcutaneous formulation is that it's faster. And so that's the main advantage, I think, of using ocrelizumab sub-Q. Disadvantages relate to how it's administered, means that you can get more injection site issues, reactions, swelling, and things like that. We would expect the risks, meaningful risks overall, though, to be quite similar because they both, as we heard from Dr. Beaumont, sort of suppress our immune system substantially, and so ongoing use does have some increased risk of infections. Thank you.
Thank you. So now we're going to speed up the lightning round. We have many questions, so we need to go fast. So no more than 30 seconds per question. Okay, Dr. Heffler, you're opening the round.
And we're on. Epstein-Barr virus has a potential. What causes Epstein-Barr? Viruses are nature's way of transferring DNA across species. They're omnipresent. Viruses go through us all the time. 93% of us in the room who do not have MS have been infected with Epstein-Barr virus. 100% of patients with MS have EBV. And recent studies suggest that the EBV virus triggers MS, but it's something we all carry. The question, does COVID further increase the risk of Epstein-Barr in MS? Probably not. Again, we've all been infected with it. Is there a possibility of a vaccine to prevent MS? Yes, I think so. How do we prove that Epstein-Barr virus causes MS? Very simple. Vaccinate against it, and a number of companies are going to do clinical trials with mRNA viruses, if we're allowed to. We won't go there. And if MS disappears, then we'll know that the virus causes the disease. So that's going to be, I think, the vaccine for it. What does research say about safety of B-cell therapies, diminished immune response? When you measure B cells in the blood, they go to zero. But there's still B cells in the lymph nodes. There's still B cells in the spinal fluid. So when you get B-cell depleting agents, even though when you go to us and we measure B cells, we'll say they're gone or 1%, they're still there. You can still fight off infection. What happened with COVID, a new infection, no one had protection. Those on B-cell depletion had a worse outcome. Before there were vaccines, we've been studying vaccination in patients on Ocrevus and Kesimpta, and you end up making a reasonably good immune response with time. In fact, the immune T-cell response is stronger. Last question, lightning, am I going fast enough? CAR T-cells. Benefits. Our research is using the therapy for compassionate use with patients with secondary progressive MS. At Yale, we are one of many centers that will be doing a phase 1 trial with CAR T cells. It's going to be both early relapsing remitting, I'm not so excited about that, but also in patients with progressive disease. Speak to anyone in the New England area. You want to go on, let me know, send me an email, david.hafler@yale.edu. Happy to set you up. But it's being done all over the country, Bristol Myers Squibb, I believe Novartis, a number of companies doing it. So it's not going to be compassionate use. That would not be appropriate, but would be appropriate as part of clinical trials. I'm very excited that we'll learn from doing that. Done.
Thank you. Dr. Rosel, do you have questions you want to take over? Yeah?
Okay. Hi, yeah, sure.
Lightning round.
Yeah.
Lightning fast.
Lightning.
Okay, all right, we just wasted 15 seconds on that. I'm just saying, I get this back.
60 seconds.
Okay, so I get 20 seconds back. Okay, anyway, the question is, these interesting regeneration of myelin, future therapies. This has been talked about for a very, very long time, and there's been some disappointing results, I would say, but I'm going to twist this to something good. So if you think about, I'm a nerve cell, I have an axon, this is my myelin, I have a synapse. Can you give me your hand here? This is the synaptic connection, so I'm a nerve cell, axon, myelin, synapse, right? And on top of all of us, we've got these glial cells back here that Some of them make
I'm the
inflammatory.
glial cell.
He's a bad microglial cell that makes bad inflammatory things. We've got Adam, who's a astrocyte, who's making supportive things for the synapse. So picture that. So all the previous therapies, the therapies that have failed really for myelination, you know why they failed? Because all they focused on was the myelin and the one cell making the myelin, and they didn't take into account the fact that if this axon is damaged, you have a problem. If this synapse is no longer working and there's no activity along that axon, you have a problem. You can't myelinate something that's not going to be useful ever. Your body's too smart to do that. Or it could be a problem with some of those glial cells that are not supporting. So the beauty of it now is I think we've gone to the next level with this remyelination idea, and we know we've got to consider not just putting the myelin back, because it won't be if the axon's damaged or if those glial cells are acting up. What we've got to do is consider all of them and make the whole environment appropriate for myelination. I do think there is hope for that. Okay, the second question that was, I know more than 30 seconds, but the second question is, do you think when these remyelination therapies do come out, hopefully by considering all the players on the stage, not one, could it be that I will age out of it, so you won't be in these trials because you're too old? The question is, well, it's a good point, because we do think that younger, kids, babies make myelin, they still make it, and as you age, you make less and less. And so it is true, as you get older, we would be somewhat concerned about that. I would say, though, really, it may not be all about age. It can be that, but also, it's going to matter how long a lesion's been there. So if you've had it for a day, then this axon's still intact, right? This wire. But you try to put rubber back on the wire when the wire's been so damaged, it's not going to happen. So it's not just age, it's also what's the relative time since that lesion first started. Does that make sense? So you could be older, but if you had a new lesion, it could still be amenable to treatment. This is called a critical window for remyelination, so it's not too much damage that you can still repair it. The last question is, I like this too. I lost my short-term memory about 25 years ago. Is there any research on this? This is very important because processing speed is known to be affected in MS patients. Also, some recent memory can be affected. It's also affected by menopause in healthy women. And so we've actually done quite a bit of work on showing that estriol, the estrogen of pregnancy, actually can cause improvement in cognition. So yeah, I think it's very promising, and this is an area we need to pay attention to. It's not all about walking or coordination, it also affects cognition.
I'm going to just say one brief thing. There are a number of questions that were sort of personal questions, and I know I'm going to hang around a bit after. My flight is until later, and the others might be. So if you have any personal questions, I'm happy to hang around, try to answer them.
Okay, so the next round of questions, Dr. Weiner, do you have a couple of questions to address briefly?
Yeah, there's a question about stem cells and what's the status of stem cells. There's two types of stem cells. One is where they actually make stem cells from your own bone marrow and give it back. And those trials are going on. There's a couple companies that are doing it. We're going to be doing it. This is for progressive MS. The other stem cell is hemopoietic stem cell therapy. That's where you get a lot of chemotherapy, knock everything out, and let the immune system regenerate. So that's also being done in people who have very active MS, and that involves chemotherapy to clean out the immune system and then give it back.
Very good. So I think there's only 2 or 3 questions left. So Dr. Yadav, do you want to briefly address your question?
So one question was about medication to prevent vertigo in PPMS. So before I talk about medications, we should, or the person who has vertigo, they should try to work with the doctor to understand where is the vertigo coming from. The reasons for vertigo may not be MS by itself. There could be a problem with the inner ear, or it could be because of the circulation in the back of the brain, which is the posterior circulation issue. So those, just because we have MS or vertigo may not be just because of that, so other causes need to be figured out before the right treatment is given. Medications in general don't do well for treatment of vertigo. Let's say if it's a truly MS-related vertigo, vestibular rehab will be probably the best way to go to treat that versus medication, because medication in general, they will dampen the response of the brain to the movement, which is not necessarily good for long term. Second question was about can a 70-year-old with the stable MS, stable RRMS discontinue Copaxone? So again, that's a question which I think probably many of us will agree or disagree. Yes, so there have been trials which have looked at the exact same question where a stable MS patients can discontinue medication. So the trial, which was a randomized control trial done in US, looked at people who discontinued the drug and who continued the drug, and but there was no big difference between the two groups at 2 years time frame. However, I think it's a very individual question that should be discussed with the neurologist and see the pros and cons of that choice. So I think that's it.
Thank you. So Dr. Kaplan, I think you have one question. Brief answer, please. Sorry to be so bossy today.
No,
It's not like me.
Not at all. So I'm going to answer the question I wish I'd been asked, which very briefly. So Chad very bravely described his experience. He also characterized what his experience was having this very stressful year leading up to the onset of the worsening of his condition, which makes me want to just mention that MS causes depression. Depression is a state of severe anxiety as well as all of these things. And the reason why you want to get the depression treated is, one, depression sucks and it's a potentially lethal disease. And two, because it doubles your chance of getting MS. So it turns out depression is a risk factor for getting MS, lupus, rheumatoid arthritis, and inflammatory bowel disease. And in the inflammatory bowel disease, those people who had their depression treated had no increase in their chance of getting depression, if they were depressed, had no greater chance of getting rheumatoid arthritis. So depression, bad, treating it, good.
Thank you. So the last two questions, 30 seconds for myself. How can I get included in clinical studies? So to get in clinical trials, so studying new medications, the best two ways is you go to clinicaltrials.gov. It's a site maintained by the NIH that lists all the ongoing trials, whether they enroll or not. Then you can look at the site, the MS clinic site where you're being seen, because they may also advertise the studies they are doing, including studies that are not related to treatment, and talk to your neurologist. Last question, Octopus. So that's a drug trial. What is that? So the Octopus study is a way to design a clinical trial in progressive MS, trying to leverage the fact that you don't want to have different trials in parallel because it's increasing the number of patients who have to be enrolled. So it's just a clinical trial design that has been launched in England, but I think people are thinking about that in other countries as well. I'll pass the microphone. So I'm not sure. Do you know how to use Octave testing? So I think you're referring to a biomarker set of testing that some people can have access to. So at this point, I would consider that this is still experimental. So we don't know yet how to use the result of that testing to help the diagnosis nor treatment. I'll pass the microphone to our friend Claudia.
Thank you, Dr. Wabat, and all of the doctors. And now to conclude our program is Nancy Davis.
Okay, well, everybody, thank you so much. The doctors, I learn so much every single time I hear everything, and it's so exciting to see that there's a lot happening, and there's a lot of new ideas with AI. It's pretty fascinating as well. Just want to mention, if anybody, we had a fashion show last night by Veronica Beard. If anybody wants to buy something at Veronica Beard, they can go for the next week to their store, and they will give 20% of anything you buy to Race to Race MS. So why not shop? We all love a little good retail therapy.